Hello, everyone. This is Dr. Mickey recording a lecture on chapter 44, which is about the drugs for pituitary gland, thyroid, and adrenal gland disorders. Will be part one and part B or A in this semester, and then part B or the second section of this chapter will be discussed in Patho Pharm 2. So in this chapter or this semester, we're going to cover only the disorders of the pituitary gland. And then in the Patho Pharm 2 in the fall, we will cover the thyroid, parathyroid, and adrenal gland disorders. So the adrenal glands or endocrine glands, the endocrine glands consist of the master gland, which controls all the other glands, which is the hypothalamus, and the second gland or the second level of control will be coming from the pituitary gland. So the master, like level 1 management, will be the hypothalamus. Level 2 management will be pituitary gland, and then the third line of management, which includes all these organs and glands that will secrete the hormones. So we have 3 levels. A, or the first level, which is hypothalamus, controls the pituitary gland to produce certain hormones, and then pituitary gland also will control the rest of the organs and glands of the endocrine system, so they can increase or decrease their production of the certain or specific hormones. And these glands will include the parathyroid, the 4 small tiny glands in the back of the thyroid gland, adrenal gland, both glands on the top of the kidneys, gonads, pancreas. So the pathophysiology of the endocrine system says that indicates that this is the only system that is a ductless system. In other words, that there are no actual ducts or channels or tubes that will run from the glands to the affected site or cells, but we have hormones that are going to be secreted either from the pituitary gland or from the specific glands on the lower level of the endocrine system glands, and all of these hormones will be secreted in the bloodstream, and it will target its own cells or its target cells. So it will run in the bloodstream, and then it will affect the specific cells according to according to its function and its target cells. So from the AMP, all the this slide shows all or includes or covers almost all the glands and organs that secrete the different types of hormones from the of the endocrine system. And in the pituitary gland, you see how that we have 2 loops. We have the anterior loop and the posterior loop. The anterior loop secretes all these hormones that would control different glands and organs. The anterior lobe or section of the pituitary gland secretes the ACTH hormone, adrenocorticotropic hormone. ACTH hormone controls the adrenal glands to produce steroids, epi and norepinephrine. TSH hormone, anterior lobe of the pituitary gland, secretes the TSH hormone, thyroid stimulating hormone. And this thyroid stimulating hormone from the P gland, just from now on, just, the pituitary gland will, be, denoted or called as a P gland. So the P gland, the anterior lobe of P gland will produce the TSH hormone to control the thyroid gland so the thyroid can produce more or less of the thyroid hormones, T3 and T4 hormones. Another example of the anterior lobe of the P gland, it will secrete the FSH hormone, follicle stimulating hormone, to control the gonads. And that has to do with the ovaries and with the menstruation and menstrual cycle. LH hormone, LH, which is luteinizing hormone, and has to do again with the menstrual cycle, with the conception, and prolactin, another hormone that will stimulate the mammary glands or during the lactation to produce the milk, and other hormones like growth hormones that will have an effect on the muscles, adipose tissue, and bones. And on the adipose tissue, it will increase the elevation of the fatty acids. For the muscle, it will cause hyperglycemia, and for the bone, it will increase the growth of the bone or strengthen the bone, and that affects the growth of the bone. That's the growth hormone. So this is from the anterior lobe of the P gland. And the P gland, the pituitary gland, also has a posterior lobe that which would secrete only two hormones from the posterior lobe of the P gland: ADH hormone and oxytocin hormone. Oxytocin has to do with the ovaries and with the mammary glands. Increased contraction of the uterine contractions will be strengthened with the oxytocin. And ADH hormone has to do with the water absorption, absorption in terms of water excess or um, loss. And that's under the ADH hormone, there are two main conditions that may result from the increased production of ADH hormone, which is SIADH, syndrome of inappropriate ADH. That's the SIADH condition or disease from increased production of ADH hormone. Decreased production of ADH hormone would result in diabetes insipidus, and we'll go over both conditions later on. So this is an example of how the master gland hypothalamus control the P gland, and then the P gland produce or secrete hormones to control the rest of the organs and glands in the endocrine system. So we said the endocrine system. We said it consists of the glands that secrete the hormones, and we went over some of these or most of these hormones. The most important thing about the endocrine system, the feedback mechanism. Remember that we have hormones are secreted constantly from these different glands. So what controls these hormones in terms of increase or decrease production? There are two feedback mechanisms that govern or control the production or the amount of secretion, or the amount of how much to be secreted from these glands, and when to stop, when to decrease, to increase. All of these changes is governed and will be controlled by the feedback mechanism. And we have a positive and negative feedback mechanism. Positive, an example, most of the mechanisms that govern or control The endocrine system are of a negative feedback type. Some of the positive feedback mechanisms, for example, the production of the growth hormone would result in the growth of bones. The prolactin production, prolactin hormone produced or secreted from the P gland will result in more milk production of the mammary gland. But most of the, not just effective, but most of the feedback mechanisms that govern the endocrine system are E negative type. An example of this negative feedback mechanism would be the hypocalcemia, and how hypocalcemia would lead to the increased production of calcium. How the hormones, in other words, that how the hypocalcemia would control or result and lead to increased production of the PTH hormone, and eventually is going to result in increased calcium production. Calcium, when it's very low and when it's lower than like 8.5 or 9, so that's hypocalcemia. So when there is a hypocalcemia, that will stimulate the parathyroid glands, the four tiny glands in the back of the thyroid, these four tiny parathyroid glands, to produce the parathyroid hormone. So the hypocalcemia, decreased calcium production or calcium level in the blood, will stimulate the parathyroid glands to produce more of the PTH hormone. So what does this PTH hormone would do in terms of how would this PTH hormone increase production of the PTH hormone would increase the calcium level in the blood. The PTH hormone has three effects on three main organs. Its effect on the intestine has an effect on the bone and the kidneys. At the intestine level, the PTH hormone would increase calcium absorption in the intestine. For the bones, the PTH hormone will result in more calcium resorption, means pulling the calcium out of the bones into the bloodstream. So we'll pull the calcium from the bone to the blood. That will increase calcium in the blood. So that's called calcium resorption at the bone level. Now, at the kidney level, there are two main things that the PTH hormone would do at the kidney level. For kidneys, it may increase calcium excretion, decrease calcium excretion, so to result in decreased calcium to be excreted in the urine, and it will increase also calcium being reabsorbed back to the bloodstream. So eventually, by doing all of these four mechanisms, by the effect of the PTH hormone on the intestine, bone, and kidneys, it will eventually increase the calcium level in the blood. And that's an example of negative feedback mechanism, how the hypocalcemia will stimulate the PTH hormone to regulate the calcium level. And that's what we have mentioned and previously in terms of that the endocrine system is the ductless glands. There are no physical connection between the hypothalamus, P gland, or endocrine system or glands and the affected or the target cells. So all of these slides, just flipping through the slides because they are all EMP slides or content of belong to anatomy and physiology. So we also mentioned earlier about the anterior lobe of the P gland and the posterior lobe of the P gland. The anterior section of the pea gland produces all these hormones: growth hormone, prolactin, TSH, ACTH, FSH, luteinizing LH, MSH, which is melanocyte stimulating hormone. There is a primary P dysfunction and a secondary P dysfunction. Like the pituitary gland, sometimes it's affected by what's called the primary pituitary dysfunction, and we have also secondary pituitary dysfunction. Primary, that's when it's originating from the P gland. It's secondary from which one the disorder originates from outside of the P gland. And the disorders of the P gland with the anterior loop of the pituitary gland, either it's hypopituitarism or hyperpituitarism. And then the posterior loop is affected by two main diseases. The posterior lobe, because the posterior lobe produces two main hormones, ADH and oxytocin. ADH hormone and oxytocin. And the diseases are affected by or would result from the posterior lobe of the P gland. It's either a DI or SIADH, diabetes insipidus, or syndrome of inappropriate antidiuretic hormone. Now, hypopituitarism, which is in which there is a deficiency of one or more of the anterior lobe of the pituitary gland hormones, which would result in a metabolic problem, sexual dysfunctions, and so forth. Now, the decrease in the secretion, which is a hypopituitarism, which is a decrease in the secretion of the vital hormones, either from the thyroid or adrenal or gonads or growth hormone. So the decrease in the secretion of vital hormones from these glands, like for example, growth hormone stimulate the liver to produce substances known as somatomedins that would enhance the growth activity. Decreased growth hormone lead to osteoporosis in adults, for example. Decreased growth hormone would lead to osteoporosis. That would growth hormone makes the bone more solid and more stronger. So with osteoporosis, that could result from this osteoporosis that may result in adults from the decreased growth hormone. The hypopituitarism usually it results from either benign or malignant pituitary tumors, severe malnutrition, or or anorexia nervosa, or sometimes we don't know the underlying cause of the hypopituitarism. Unknown etiology is called idiopathic. That's unknown etiology. We don't have no idea what is the underlying cause or etiology of the dysfunction. That's when we would call that idiopathic. Or it could be from postpartum hemorrhage. Now, the postpartum hemorrhage resulting in hypopituitarism, and this is something called Sheehan's syndrome. And an example of the postpartum hemorrhage leading to hypopituitarism, because what they found is that this hemorrhage postpartum could have resulted in or caused the decreased perfusion to the pituitary gland, and that's why it led to the hypopituitarism. So there are too many levels or ways to assess and diagnose the hypopituitarism. The diagnosis, we can run a series of hormones like T3 and T4, thyroid hormones, testosterone, estradiol or steroids, or LH hormone, FSH hormone. So we need a quite very comprehensive coverage of all these hormones ACTH hormone, prolactin hormone, and we do something called stimulation tests. In addition to the CT and MRI and angiograms, all of these things should be done to diagnose. This is very comprehensive because we are covering the P gland, pituitary gland. This is the gland which controls all the underlying endocrine organs and glands. So we have to review all the hormones in addition to the diagnostic testing like diagnostic tests like CT and MRI or angiogram to find, to figure out which hormones are significantly reduced in terms of production. And we can, rely on these findings as we diagnose towards hypopituitarism. In terms of interventions, that which will be covered extensively or more in depth and Patho and mid-surge adult health 3 course. The intervention here in the pituitary gland depends on which hormone is affected. So we have to do a replacement of the deficient hormones. If that's an androgen, then we have an androgen therapy for virilization. And virilization, which is the presence of the male secondary sex characteristics. And that may lead to gynecomastia as a result or side effects from the androgens. The androgens should not be prescribed and should be avoided in men with prostate cancer. Estrogen and progesterone, and that even though there is, from the Women's Health Initiative, they found that these hormones are associated or correlated with a high risk for hypertension and DVT and blood clots. Hypopituitarism, there are two conditions here with the hypopituitarism, either dwarfism or a DI. So dwarfism, which is a short stature caused by deficient levels of growth hormone, and Davis insipidus will be discussed also later on in this chapter as the endocrine system condition or disorder in which there is a decreased production of the ADH hormone, deficiency of the ADH hormone. So to explain about the prostate cancer from the previous slide is that the prostate cancer, what shouldn't the prostate cancer should be a contraindication for the estrogen for the androgens. So patients with prostate cancer should not receive androgens because prostate cancer growth is largely dependent on the presence of the androgens. So therefore, androgen deprivation is primarily a therapeutic approach for some men with prostate cancer. So the hormone therapy known as the androgen deprivation therapy, ADT, androgen deprivation therapy, ADT, is focused on reducing the levels of circulating androgens in order to reduce the tumor growth. And that's why the prostate cancer is a contraindication for the androgen therapy. So we said the hypopituitarism, decrease or deficiency of the hormones like dwarfism, like growth hormone, and Davis insipidus, which is the decreased production of ADH hormone. Hyperpituitarism, the hormone oversecretion from the pituitary gland, primarily, usually either there is a tumor or hyperplasia. So occurs most often in anterior pituitary cells that would produce um, the growth hormone, prolactin, ACTH hormone, MSH hormone. So most common cause, benign adenoma. That's a hypothalamic problem. The neurologic symptoms may occur with or status post after increase in adenoma size. So the adenoma, which is a tumor in the pituitary gland or affecting the P gland, when this tumor or adenoma size becomes large or big enough and exerts pressure on the brain tissues, that's when the patient would start to exhibit neurologic symptoms. And just to highlight that the P gland, this pituitary gland, very small, tiny gland, it's usually situated in a bony structure called sella torsica. Bony structure called sella torsica. And any increase in the P gland or it's affected by a tumor or adenoma, then the size would increase and that will exceed the size or will affect the adjacent brain cells and brain tissues. And that's when the patients start to begin exhibiting the neurologic symptoms. Prolactin secreting tumors. Sometimes tumors would affect the P gland, and it starts to produce large amount of prolactin hormone, like galactorrhea, amenorrhea, infertility. That would result from that prolactin circulating or secreting hormone tumors. Hyperpituitarism, in which there is an increased production of the hormones, like in growth hormone, that's going to result in either gigantism or acromegaly. So slight difference or minor difference in terms of the gigantism and acromegaly, because both of them, there is an increased production of growth hormone. However, it's the onset. It depends on the onset of the disease process. If the onset of the growth hormone oversecretion or hypersecretion would begin before puberty, then that's a gigantism. But it's an acromegaly after that. So it depends on the onset of the hypersecretion of the growth hormone. That's gigantism versus acromegaly. For the acromegaly, the early detection is a key. Well, same thing with the gigantism also. Before puberty or after, gigantism before, acromegaly after. The key and the key towards not just diagnosing, but also to treat for effective treatment is the early detection of the problem. The growth hormone is an insulin antagonist. In other words, more growth hormone, patients who receive growth hormone, they are at risk for hyperglycemia, increased glucose level in the blood. Increased blood level, hyperglycemia from growth hormone, because growth hormone is an insulin antagonist. Excess of ACTH hormone. If this patient is affected by problem with the increased production of or excess of ACTH hormones, adrenocorticotropic hormones from the P gland, which are going to stimulate the adrenal glands to produce more hormones, especially steroids, which is called Cushing syndrome. So Cushing syndrome, which is excessive cortisol level, which has resulted from the increased ACTH hormone production. by the P gland. Hyperthyroidism, also it may, which is hypermetabolic state, which is usually result in increased production of T3 and T4 thyroid hormones. That's in response to an increased TSH hormone, thyroid stimulating hormone from the P gland. So drug therapy or medications or different meds to treat different conditions. For example, for the adrenal gland, which produces the corticosteroids, steroids, and disorders will be hypersecretion, which is Cushing syndrome. Patients will have a moon phase, will have a weight gain, they will have a fluid excess, there will be a hyper tension, increased blood pressure, hypokalemia, and hypernatremia. All of these are thin muscles, fragile bones or osteoporosis, and more adipose tissue in the trunk. So that these are all symptoms or manifestations of the Cushing syndrome. Patient will be treated with ketoconazole, Nizoral, which is antifungal, and Magitine, Lesodran. With the hyposecretion, they will receive, which is an Edison's disease, hyposecretion, where there's decreased adrenal gland secretion, they will be treated with hydrocortisone, which is a steroid, or prednisone. Other conditions will affect the P gland, pituitary gland, and certain medications to be prescribed, such as the demopressin, for example. Demopressin or vasopressin, which is a synthetic form of the ADH hormone, that's when there is a hyposecretion from the anterior lobe of the P gland. So that will result in diabetes insipidus. So these patients would receive a demopressin or vasopressin as a synthetic ADH hormone as a treatment or drug. Patients with a hyposecretion of growth hormone, in which they will have a small stature, they will receive a somatotropin hormone. And they won't continue receiving that. They will receive it until the virilization has been reached. The opposite or the contrary and the other side of the growth hormone when it's oversecreted. So hypersecretion of the growth hormone, which has resulted in acromegaly or gigantism, that will be treated with octreotide sandostatin. And octreotide sandostatin has off-label uses other than it's being prescribed or manufactured to treat patients with acromegaly or with the increased growth hormone production, acromegaly or gigantism. But also it has other indications. Octreotide sandostatin also can be given for nausea, but it's specific to cancer-induced nausea. And also it can treat patients with a brain tumor. Oxytocin, when there's a hyposecretion, delayed delivery, or lack of milk ejection, that would be treated with oxytocin or pitocin hormone. Thyroid, patients with hyper versus hyposecretion. Patients with the hyper secretion of the thyroid, like Graves' disease, or hyperthyroidism like Graves' disease, they'll be treated with a PTU, propylthiouracil, or radioactive iodine 131. And patients with hyposecretion of the of the thyroid hormones like T3 and T4 sometimes would affect even the older adults. It's just with the aging process that the thyroid hormone become less effective, less producing um, less than what we need from the T3 and T4. So decreased production of T3 and T4 due to the older, aging process will result in hypothyroidism. And patients will be treated with the thyroid hormone. Octreotide is a very important drug. Demopressin also, bromocriptine, paralodil, another important drug. Demopressin, octreotide, simvastatin. The interventions may include non-surgical management, drug therapy, the dopamine agonist like paralodil. Paralodil, that drug will stimulate the dopamine receptors in the brain and inhibit the release of the pituitary gland hormones like prolactin, growth hormone. The octreotide, another drug other than the paralodil, would be the octreotide sandostatin, which is a growth hormone receptor blocker. Radiation therapy can be included as part of the management, but that's the long-term treatment and may take several years for this to result in actual or effective results. Um, the disorders of the posterior T gland, posterior pituitary gland. So patients either it's an increase or decreased production. So the decreased production of the ADH hormone would result in diabetes insipidus. That's an ADH hormone deficiency. So the diabetes insipidus is classified as either nephrogenic, primary, central, neurogenic, is the same thing, secondary, or drug-induced. Nephrogenic type of the DI is due to the renal tubules that they do not respond to the actions of the ADH hormone, which is most likely is going to be inherited genetic disease. Nephrogenic, that's when the renal tubules do not respond to the actions of the ADH hormone. It's mostly inherited genetic. Primary type, which is when there is a defect in the hypothalamus or pituitary gland. Secondary, when there is a tumor or head trauma, infections, or hypophysectomy or metastasis. Hypophysectomy, which is the actual removal, the surgical removal or excision of the pituitary gland. hypophyseectomy. That's the surgical excision or removal of the P gland. Drug-induced, there are certain medications that will, may lead to diabetes insipidus, like lithium carbonate, diclomycin, or demyclocycline. Diclomycin, which is the generic name, DECLOMYCIN, diclomycin, and lithium carbonate. These are two out of the long list of medications, but these are the most common ones that may lead to diabetes insipidus. So the assessment, diabetes insipidus related to dehydration. Now, there's an increase in frequency of urination and excessive thirst. These are the two main manifestations that are consistent with diabetes, either insipidus or mellitus. Same thing, right? There is a polyuria and polydipsia, and that's from excessive urination. And the more fluid we lose, the more likely we're going to, or high likely we're going to experience thirst, polydipsia. So diabetes insipidus, the two main manifestations would be polyuria and polydipsia, and that's because we don't have enough ADH hormone to hold the fluids. So most of the fluids be lost in the urine. So the patient will have, will experience fatigue, nocturia, and they will lose lots of fluids in the urine, goes up to 4 liters of urine daily. In terms of diagnostic testing, like the dehydration water deprivation test or hypersaline, hypertonic saline test, all of these tests will be covered in adult health 3. But here we're going to highlight the most important manifestations and signs, symptoms, and pathophysiology, and not that too many of the medications, but most of this is going to be pathophysiology, less of pharmacology. So as we assess patients with diabetes insipidus, you will find out that from the decreased amount of ADH hormone, and remember that the ADH hormone is to hold the fluids. That's the antidiuretic, so it will prevent the uricase. When we do not have enough of this ADH hormone, the fluid will be lost. So that's why the urine will be diluted. So from lots of urine will be lost. So we have diluted urine and we have concentrated blood. So everything is very low when it comes to the urine that is diluted. Urine specific gravity is low, osmolarity is low, that's not concentrated, diluted. The pH, the sodium, potassium, everything is very low because that's diluted urine. But the blood's going to be, because we are losing too much fluids, the blood will become concentrated and everything is going to be elevated. Osmolarity is the sodium, potassium, everything is going to be concentrated in for the blood. Now, which is the following is possible outcome of the client experiencing age-related decrease in antidiuretic hormone? So when there is a decreased ADH hormone, we anticipate diluted urine and polyuria. Diabetes insipidus, in terms of the interventions, and most of this also would be extensively covered in the adult health 3. So it depends on the severity of the disease process or the disease. If that's mild, severe, moderate. So for example, mild diabetes insipidus, it will be treated only with the diabinase tablet, oral diabinase tablet. Severe DI or diabetes insipidus will be covered with or treated with demopressin. Demopressin acetate intranasally spray. The ADH hormone stimulant, which is carbamazepine tegretol. If you go from the class when we covered the anti-epileptic medications, anti-seizure medications, one of them was the carbamazepine, which is tegretol. It's also an ADH hormone stimulant. The pitressin can be given, or demopressin, it can be given. Uh, we can prescribe it for patients with ECAD, coronary artery disease, but we have to give it, administer it with caution for patients with CAD because of the vasoconstriction. That's pitressin, or uh, vasopressin, because it's a vasopressor. So early detection of the dehydration and the maintenance of adequate hydration is a key, very important. You treat it with IV therapy with frequent monitoring of the electrolytes. So I have to keep, continue or keep doing electrolytes while patient on IV therapy. We have to measure take a daily weight early morning before breakfast, same clothes, control all these confounding factors in the morning. We have to continuously also continue to assess all the signs and symptoms of the dehydration, like assess mucous membranes, skin turgor, um, promote safety. Sometimes that will result in a orthostatic hypotension, so you have to promote safety. So the lifelong vasopressin should be prescribed for patients with permanent condition of diabetes. So patients with the DI, permanent condition of diabetes insipidus, patient will be lifelong vasopressin therapy. Also, patients on the vasopressin or demopressin, to teach them that the polyuria and the polydipsia are both signals to take another dose of vasopressin. So it says that the ADH hormone conserves water in the body. The demopressin or vasopressin or pitressin, it's all same medication. It has a short duration of action. Its duration of action about 2 to 8 hours, and usually given either IM or IV route. The so basically the patients with a DI, especially with the permanent DI, they will be treated with a synthetic source of ADH hormone, demopressin, vasopressin, pitressin. And now patients with the on the other side, the contrary to that, would be patients whose posterior lobe of the pig gland produces too much of ADH hormone, which is a syndrome of inappropriate ADH hormone. So the vasopressin is secreted even when the plasma osmolarity is low or normal. Causes of the SIADH hormone would be malignant tumors, head trauma, CVA, certain medications like lithium, dilantin, phenytoin, alcohol, also another cause for SIDH. So when there is lots of ADH hormone which would lead to more fluid to be retained. So water is going to be retained and result in a dilutional hyponatremia. even though the patient is going to retain lots of fluids or water, that would not result in will lead to hypernatremia. It will be hyponatremia because dilutional hyponatremia. So the patients with a SIDH will exhibit the following symptoms or manifestations: fluid excess, weight gain. There is no edema in SIDH because that's dilutional hyponatremia. Fluid volume excess. Patients would have tachycardia, crackles. And here you would find that the patients with SIDH, remember that with the DI, the diabetes insipidus, we said that the urine is diluted and the blood is concentrated. Here's the opposite. We have fluid retained, fluid excess, we have weight gain. So we have less urine and more fluid retained. So in other words, that the urine is going to be concentrated. However, the blood will be diluted. So interventions would be to restrict the fluids, so about 500 to 600 mL daily. To dilute and irrigate the G tubes with the normal saline because the patient has the hyponatremia. So we have to give more sodium. In addition to daily weight and taken output measurement. Medications, diuretics, so that will increase diuresis, diuretic medications to increase diuresis. At the same time, you would also add a hypertonic solution, 3 up to 5% of normal saline. So you want fluid to be voided or removed from the body with the diuretics medications. In addition to also, you need to have to add a hypertonic solution, 3 to 5% of sodium chloride. Dimeclocycline or diclomycin. And this is a tetracycline derivative. So this drug may take a few weeks to see any results and reach any effective outcomes from using this medication. And also we have to make sure that patients who are allergic to tetracycline should not receive the dimeclocycline or diclomycin because that's the tetracycline derivative. The side effect from the drug, it can cause drug-induced diabetes insipidus and may cause oral thrush or the wet cheesy film in the mouth, which is more of the fungal infections. So the advice or the tip for those who are using diclomycin is to rinse the toothbrush with diluted bleach and make more and to take and ingest more of the yogurt. Now the lithium also can be taken as another treatment. In addition to also safe environment to reduce the environmental noise and lighten and light, less strong light or less noise and to take also seizure precautions as much as we can and to assess for neurologic assessments every 4 hours.